Join Gino K, MD, as he breaks down the most important updates in rare melanoma and advanced skin cancers from MOASC. In acral and mucosal melanoma, response rates to single-agent PD-1 inhibitors remain under 25% in many series. Dual immunotherapy with nivolumab plus ipilimumab has shown response rates of 30 to 40% in some rare melanoma subtypes. BRAF-MEK inhibitor combinations produce response rates above 50% in BRAF mutant cutaneous melanoma, but benefit is more limited in rare subtypes. Uveal melanoma continues to show median overall survival under 2 years in the metastatic setting, despite new targeted options. Tebentafusp has demonstrated an overall survival benefit in HLA-A0201 positive metastatic uveal melanoma. In 3, 2, 1. How do the OptimUM-02 results with Darovasertib plus Crizotinib influence your first-line choices for metastatic uveal melanoma?
So the OptimUM-02 trial is an extremely important one for the treatment of patients with metastatic uveal melanoma. We know that these patients do not qualify for treatment with tebentafusp or Kimmtrak if they are HLA negative, meaning the only other standard option might be immune checkpoint blockade, which historically has shown very short progression-free survival and very low response rates. Because this new combination of Darovasertib with Crizotinib targeting PKC and MET clearly improves progression-free survival, and this was a randomized trial proving this, we think that this will probably become the new standard of care. Hopefully we'll get FDA approval and become an important regimen that really helps these patients with this disease.
What activity have you seen with the new PD-1 VEGF or PD-1 CTLA-4 bispecific antibodies in mucosal melanoma?
Compared to cutaneous melanoma, we know that mucosal melanoma is a very different disease. It is an immune cold tumor type with a low TMB. We know that these patients do not respond as well to typical immune checkpoint options. Instead, we know that drugs which target VEGF can have some activity in these tumor types, and combining VEGF with PD-L1 seems like a more effective approach for this tumor type. This trial demonstrates 2 novel bispecific antibodies, one which targets PD-1 and CTLA-4 combined with a VEGF inhibitor, and another one with a PD-L1 VEGF bispecific together with a VEGF inhibitor. We see some interesting activity here. I think this further supports the rationale for targeting immunotherapy checkpoints together with angiogenesis in this tumor type, and hopefully provides further evidence of exploring that mechanism of action in this disease subtype.
How are you approaching patients with Merkel cell carcinoma who progress after anti-PD-L1 therapy?
Unfortunately, patients with Merkel cell cancer who've already been treated with PD-1 or PD-L1 inhibitors have very, very few options, and this is a very aggressive disease. If these patients can't be treated with radiation or surgery, the only other remaining systemic therapy options might be something like traditional chemotherapy, which we know can work, but for very short periods. So we need other options, especially ones that might help prime an immune response. And an ATR inhibitor based on the Matrix trial may suggest an important agent that, when together combined with PD-L1 inhibition, may salvage those patients who didn't respond to PD-1 or PD-L1 alone.
Why do rare melanoma subtypes and other skin cancers often need different strategies than cutaneous melanoma?
We know that rare melanoma subtypes, such as uveal melanoma, mucosal melanoma, also acral melanoma, have a very different biology from skin melanoma, which represents 95% of all melanomas. We know that biologically they're different at a molecular and genetic level, and we know that they also do not respond to the same immune checkpoints that have led to such promising outcomes for traditional skin melanoma. This is a very nuanced thing, and one that only is, I think, well understood by people who really see a lot of these rare subtypes. And so we encourage people to consider asking for second opinions or referrals, so that for these rare subtypes we ensure that they get the proper treatment approaches based on the latest research. This also can apply to rare skin cancers such as Merkel cell skin cancer as well.
If you like this video, take a look at the web post companion on OncologyTube.com, which includes more detailed information. Thank you for watching.